Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. Can you hear me now? Can you hear me, Jesse?
I can hear you. Yeah.
Okay. Can you hear me now? Okay, I hear me in the thing. All right.
But now the feedback.
Can you hear me? Oh, good Lord. If it ain't one thing, it's another. Can you sing that song? If it ain't one thing, it's another. Okay. You said the feedback is back.
Yeah.
How about now?
It's slightly, but it's tough.
Okay, let me turn me down. Okay.
Now she's saying yeah.
Okay. Sorry. Well, welcome everybody. Welcome. Sorry, we missed the whole intro. Y'all know what we do. Y'all know what we talk about. No. We just introduced everybody and welcomed you to the Saturday morning tea. If you're listening on the replay and you missed those few moments, she said you hear it. Hey, Renee. Thank you. Hey, ma'am. Hey, Asha, how are you? Okay. So, in Clubhouse, feel free to click the link if you are interested in getting more information about the 5 steps to become a certified marketable medical coder. YouTube, Facebook, and LinkedIn. You can check the video description for the link. I promise you, it's in there. It's down there. All right. So joining me today is my co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been an LPN for 30 years. And I transitioned into HIM in 2014. But during the pandemic in 2020, I created a company called the Coding Nurse, where I help nurses and other clinical people with healthcare with a clinical background transition into the wonderful world of HR.
Yes. Okay. And how's that working out for you?
It's coming along nicely.
Yes, I love it. I love when things come along nicely. Unlike this stuff right here. Oh, cool. So, how was your week? It's been crazy. This is probably has been one of the busiest weeks. I'm like, is something going on? I know we experiencing all kinds of global warming and temperature warming and all of the things, but good Lord, slow down. Let's relax. It's summertime. We're supposed to be relaxing. Okay. Well, yes, next week. This year is gone. Summer is over. Kids go back to school, I think, in 2 weeks or so. I know. Well, before we jump in, let me remind you that you can join in and add to the conversation. Remember, this is a conversation. While we may bring the topics, we want to hear from you. We want to know what your thoughts are on the topics that we discuss and your feelings. And don't be shy. Don't be shy. If you are on Clubhouse, you can raise your hand to join in on the conversation. Good morning, Shay. Um, if you are on Facebook, YouTube, and LinkedIn, y'all already know what to do. Use the chat. Use the chat. If you have a question, put a Q in front of the question so that we know it's a question for us and we don't miss it. For those who are joining us today, we are talking micro-credential, AHIMA micro-credentials, and is coding destroying everything? Look, I didn't have enough characters because I would have been like everything, everything. But they wouldn't let. I only had 75 characters for a title. All right. But before we jump into our topics, let's get into our church announcements. Our church announcements. All right. And I had the fan. I should have just kept the fan over here. I'm gonna keep the fan over here. And I still am in search of a Martin Luther King church fan. If anybody has one, please let me know. Please let me know. Okay. So our church announcements today. I got a couple of things that's on the brain. Okay, let me get out of this. Oh yeah, she's here for that conversation. Yes, ma'am. Ma'am. That's a whole conversation. Okay. So this, I think it was this morning, or was it last night? Sometime or another. Did y'all hear about? No, it was this week. Because today I saw another lawsuit. Folks are litigious. Let me just say that. Litigation is flying. Attorneys said, you know what? We haven't done much in COVID-19, but guess who's coming back with a bang? Y'all thought it was these physicians. It's these attorneys. They are coming back with a bang. And there is a civil rights investigation against Cedars Sinai. What did I do with that? There was a whole issue related to a mother who, I think she passed. Wait a minute, let me pull this up. Had you heard the story? Did I put it in our notes?
It was Kira Dixon.
Oh, here we go. Okay. I don't have it on my screen. Okay. So Cedars Sinai faces civil rights investigation in the death of Kira Dixon Johnson with complaints of racial discrimination. There is now a federal civil rights investigation. So please indulge my public health side today. Because we have talked about over and over and over again all of the things that are happening with maternal mortality and how the United States has a high rate, and it is actually is going up, not going down, rate of maternal mortality compared to other nations that are like us. Actually, in some cases, we're higher than some of the less financially astute nations in the world, which is crazy. Well, folks have been talking about Cedars, my understanding, and allegedly, get all that out. According to this article by Sarah Morse, folks have been talking about Cedars Sinai for years and how they have treated Black women during childbirth. Well, the United States Department of Health and Human Services got wind and decided to open an investigation in response to all of the allegations of racism and discrimination, specifically following the death of Kira Dixon Johnson. So, some background: in April 2016, Johnson underwent a cesarean section at Cedars Sinai to deliver her second son, and she died hours later after hemorrhaging blood. She had told her doctor about blood draining, and a surgical emergency CT scan was requested. Her husband also pleaded for her to be readmitted to the operating room, and he was informed that his wife wasn't a priority, end quote, according to the lawsuit. By the time, and they filed a lawsuit as well, the family. By the time Kira was admitted into the operating room, doctors found 3 liters of blood in her abdomen and died shortly after from hemorrhagic shock. When Kira died, nearly 90% of her blood was found in her stomach, according to their attorney. And it was also found that her bladder had been cut and had been improperly sutured. Said it shocked everybody that we deposed, all the healthcare providers, even the head of obstetrics, the head of labor delivery looked at it and said, no, I've never seen one done that fast. So the Office of Civil Rights sent a letter to Charles Johnson in March, letting him know that they have been made aware of concerns regarding the standard of care provided to Black women in the care of Cedars Sinai Medical Center. Specifically, OCR is aware of allegations that Black women are provided a standard of care below what is provided to other women who are not Black when receiving healthcare services related to labor and delivery. They're assessing whether the hospital is adhering to federal civil rights laws, considering the allegations and the fact that Cedars Sinai receives federal funding. Let's see. Maternal health is a priority for the Biden-Harris administration, and one in which the HHS Office of Civil Rights is working on around the country to ensure equity and equality in healthcare. The Cedars Sinai Medical Center responded to the lawsuit last year in a statement saying that they reject any mischaracterization of our culture and values, and they were actively working to eradicate unconscious bias in healthcare. And those were quotes. For this investigation, that was last year's lawsuit. So they also responded to this investigation saying Cedars Sinai clinicians, leaders, and researchers have long been concerned with national disparities in Black maternal health, and we are proud of the work we've done and continue to do to address these issues in Los Angeles as well as at the state and national levels, end quote. So that was their response to this new investigation. The statement also shared their commitment to Black maternal health through partnerships with advocacy organizations like California Maternal Quality Care Collaborative and Cherished Futures for Black Moms and Babies. They also noted that they provide unconscious bias training to their employees, conduct clinical studies that research Black maternal health, and provide over $2.2 million in grants to nonprofits in LA aimed at improving maternal health disparities. However, despite nationwide attention on Black maternal health disparities, the number of women who die from childbirth each year is climbing, and Black women bear the brunt of that reality. From 2020 to 2021, maternal deaths in the U.S. increased by 40%, according to data from the CDC. Black women are more than 2.6 times likely to die in childbirth than white women. Whew, that was a whole lot. But I was like, okay, OCR, I'm glad y'all getting in the fight and conducting this investigation. Mr. Jesse, did you have anything to?
I really did. I have a whole lot to say. Because, I'm just over the vulgar. And that's not, I don't even really want to say vulgar.
I know you don't.
Because this is just as much our fault as it is their fault. Because this has been going on for far too long. And I want to know, like, you have all of this, like we have all these organizations, we have all these groups, we have all these Black professional women's organizations. How come Black Greek organizations aren't talking about this? How come the links aren't talking about this? How come they aren't talking about this in churches? This should be a conversation that we should be having, because at the end of all of this, and nobody to heck with it being a Biden-Harris initiative. I mean, what have they done for us, period, since they've been in office? Nothing. So that's just lip service to me. But it's just racist, point blank. And it's always been an assault on Black people. And it's this whole numbers game, because the powers that be, white folks, have been upset about the browning of America anyway. So guess what? A dead woman can't reproduce. Period.
It's crazy. I'm like you. There's so much happening around this work, but not enough for us to be talking about it. It impacts, and again, with my public health hat on, and this isn't the only issue. There's a few other issues that we really need to have some for real conversations about. I in my opinion, I think. But go ahead.
Wasn't it just last year that it came out that this OBGYN somewhere was giving all these Latina women hysterectomies unnecessarily?
It's bananas. And like, why, to your point, why are we not having these conversations? Why, where we gather, are we not having these conversations? I mean, these one-off individual conversations is one thing, but collectively, there's a lot happening. And if we could talk about what somebody's baby mama did to somebody else, or that didn't get a car back, or, which has nothing to do with us, doesn't advance us at all, period. Why can't we have these conversations on some serious things that impact us all? Not only those of, well, I'm out of childbearing years, but those in the childbearing years and our future. Why wouldn't you have this conversation? What's going on? What can we do? How can we in our community mitigate this? What conversations do we need to have? What type of training? What do we need to talk to our physicians about? Maybe put together a checklist. When you go in and talk to your OBG, and make sure this, and the third is addressed. Have them, talk to insurance. Make sure it's really probably blame to go all the way around, but just making sure that folks are informed and informed enough to have conversations with their healthcare providers, and informed enough to have conversations with their families. Hey, I went to the doctor and this wasn't right. Has this ever happened to you? This, that, and the third, and had those conversations. Wait a minute. Now we got a group of people who may have experienced some similarities with, one, a particular provider, or two, a particular institution, or three, a particular insurance carrier. We got numbers. And we need to pull together to have these conversations about what's going on. Okay, let's see. Crafty Coder says, yes, Jesse, we are all at fault. We all have to do our part. Absolutely. Clarice, people feel like if it's not them, it don't matter. Problem with that is, who gonna help you when you need it if you didn't help when it wasn't you? Exactly. You need to get out of that. Okay, somebody's saying you are low. Are you low on my side or low on your side? Okay. Do you hear feedback?
Just a little bit.
Okay. As I tried to turn you up. Let me see. Wait, let me turn down this way and turn up this way. How about now?
It's still the same. It's all
right. Okay. I'm sorry. I'm trying to get it in. Yeah. So That was the other thing. Yeah, the other lawsuit I saw, I'm trying to find it because I saw it must have came this morning about Cigna. It's a whole class action lawsuit against them. Using this happened 3 days ago. Using an algorithm, or allegedly they're being accused of using an algorithm to automatically reject patients' claims. Yeah. So the feds are coming after Cigna, and they have rejected automatically hundreds of thousands of patient claims without examining them individually, as required by California law. The class action lawsuit was filed on Monday in Sacramento, saying that more than 300,000 payment claims in just 2 months last year were rejected. And they use this algorithm called PXDX, shorthand for procedure to diagnosis, to identify whether claims met certain requirements. Says spending an average of 1.2 seconds on each review, according to the lawsuit. Huge batches of claims were then sent on to doctors who signed off on the denials, the lawsuit said. Relying on this system, Cigna doctors instantly reject claims on medical grounds without ever opening patient files, leaving thousands of patients effectively without coverage and with unexpected bills, according to the lawsuit. It says ultimately Cigna conducted an illegal scheme to systematically, wrongfully, and automatically, I know the lawyer wrote all of that, deny members' claims to avoid paying for medical necessary procedures, the lawsuit contends. Cigna, which is based in Connecticut, has 18 million U.S. members, including more than 2 million in California. And this lawsuit was filed on behalf of 2 Cigna members in Placer and San Diego counties who were forced to pay for tests after Cigna denied their claims. The lawsuit accuses Cigna of violating California's requirement that it conduct thorough, fair, and objective investigation of bills submitted for medical expenses. It seeks unspecified damages and a jury trial. Woo! They coming for everybody, right?
Oh, they sure
are. Let's see. What she said. And the edits to flag claims too. Yes, the edits. Unpopular opinion. I agree with the edits because the doctor's documentation ends up not meeting the medical necessities. So fix your stuff and no edits will deny. But who asked me? We asked you. And thank you for sharing your opinion, whether popular or not. Wait a minute, 1.2 seconds. It takes longer than that to post a clean claim properly. You are absolutely correct. Yeah, this is off the chain. And so more to come on that. I'm sure it will be all the buzz. Like I said, it just popped up in my feed this morning, and I was like, wow. Always make the physicians accountable too. Exactly. Well, something I read, I don't know where I got it from initially. Maybe it was LinkedIn, because it had a post of the whole lawsuit. It had the legal documents and something about I think the doctors are involved because the doctors actually signed their names. And so the physicians that were part of Cigna's group who rejected signed off on those rejections, which is something different than what most people have and most people do. So this is going to be huge. As audits come down the pike. Folks have been up in arms talking about medical necessity for years. as we talk about one of our topics is coding destroying everything. This parlays into that. But let me give you one more church announcement that sent me into a tizzy this week. Actually, it was last week, but we didn't meet. So here locally, it still pisses me off when I think about it. But here locally, we have a nonprofit agency who I just happened to be driving down the street. Well, I heard it before. Let me back up. I heard this information before some weeks ago, months ago, actually. I think they had their first training, but I really didn't pay attention to it. I understood it to be like a coding training. Didn't go into any detail. They didn't call me, so it wasn't none of my business. Kept it moving. But then I heard it again recently, and I actually became privy to the flyer. Now, I'm like, okay, I heard billing and coding training program. That first sparked my whole thing, because as we all know, billing is a profession and coding is a profession. Billing and coding together is not a profession, but I digress. So then I'm listening, and it's going on. It's a free 12-week training program. Again, it's geared to brown and Black bodies. This organization does a lot with the underserved, and so it's geared specifically to them. And so, again, outside of the billing and coding piece, I'm like, okay, wait a minute. But what sent me on the warpath was that they're preparing them to take a certification from the National Health Career Association. Have you heard of these people? No. Okay. That was one. Two, they have a Certified Billing and Coding Specialist exam, or CBCS. Have you heard of this certification?
I have vaguely.
Have you seen CBCS on any job posting that looks for coders ever? In recent past, I've never seen. We fighting to get just the regular coding credentials added to some of the positions. I've never seen this. So what hit me first was, one, you're doing these people a disservice, because, let me back up. It also says on this flyer, career placement assistance upon successful completion of the CBCS exam. So when I read that, I thought, well, maybe there's some organization or there's some entity that accepts this credential somewhere. I know, in looking at several LinkedIn ads and what's the main thing that you see? I'm drawing a blank. For jobs. I can think of it. Indeed. There you go. LinkedIn, Indeed, they both crossed over. I've never seen this. I see AHIMA credentials. I see AAPC credentials. And then depending on the specific position, as we've talked about, like if they're going into CDI, then you may see additional credentials. If you're going into tumor registry, you may see additional. I've never seen this. And so for me, this is doing those people who spent 12 weeks training, thinking they are now a certified coder or biller coder or whatever that entity is, and can go out here and attack the world, is wrong to me. Just wrong. Because then you're frustrated, because when you go out here, you beating the pavement, you trying to get it. She said nobody checking for CBCS. You beating the pavement, you trying to get a job. You feel like you've accomplished, because you've passed this training, you've passed this certification, and you out here and you getting slammed over and over and over again, Because one, your resume ain't even hitting the appropriate people, because if we all know it hits a computer first, and CBCS is not one of those keywords that they're checking for. It's going away. It's gone. It's bye-bye. And then so now you feel in your feelings, and then you want to bad talk or trash the profession because you couldn't get a job. Well, unfortunately, the folks who were training you didn't tell you this. You may need to get some additional certifications. Let me be the first to tell you, please go get some recognized, nationally, internationally recognized certifications. I mean, we beat up our organizations here on the regular for different reasons, but however, those certifications have been recognized. Employers know about them. These all folks know about AHIMA and AAPC. I don't know National Health Career Association. I don't know. But I feel some kind of way, particularly because this is targeted at brown and Black people looking for a career, thinking that this may be a way to get into a career. I mean, because I saw, after I heard it, I went to the place's page and I saw a post and everybody tagging people in like, oh, this is this. And I'm like, oh my God, make it stop. Make it stop. I feel some kind of way. And so so I know this is here in Cincinnati, Ohio. It may be in your areas too. Please stop it. Please stop it. And please stop it. Please. And let the folks know that they need some nationally recognized certification. Go ahead, Mr. Jesse.
Mommy Picasso put in the can you mute, because there's a lot of people.
Go ahead.
Mommy Picasso put.
Wait a minute. Okay.
Mommy Picasso put in the chat. I told someone that I'm a medical coder. She said she went to billing and coding school. So I asked her for a certification and she didn't have one and didn't understand what I was asking. She paid $15,000.
Jesus. Oh my God. Oh my God. I can't. What is a billing and coding school? Okay. This took a whole life of its own. What in the whole world? Oh my God. Oh my God. This is just crazy and so sad that they're taking people's money, taking people's self-esteem, taking people's, you feel accomplished, you've done the right thing. You did your part. You done spent countless hours studying, going to classes, doing all the things that you think you need to do. And this stuff is just not right. And nobody understands this.
They don't.
Okay. Let me see. What hold on. Because my chat is on fire here. Okay. Let's see. It's not the same. It's not the same thing. It is not the same thing. Yes, that's the bootleg AAPC. Ma'am. Yes, a mess. Hello, Raspberry. I see a lot of people who get CBCS and don't realize it's not accepted until after they start applying for. Where are these people? This is my first time ever hearing of this in life, and maybe because I'm too far down the rabbit hole with the other folks. I've never, ever. Again, she said nobody checking for CBCS. There are quite a few schools that offer it. Really? So are these those ones that have coding and billing together as a training program? Part of the reason when I got my instructor certification, I didn't go to a school to teach. Yes, some of these schools are suspect, and it's unfortunate. Some of these programs, and it makes it hard for those of us who have some legitimate trainings going on. It makes it hard because of this foolishness out here in this world. Oh, Jesus. Very misleading. It's a Facebook ad out there. I was all in them people ad saying, do not listen to these people. Let me help you. I hear you. And some schools just teaching front desk, making them think that that's another thing. That is another thing. I've seen and heard that. So really, you're just the person taking the insurance card. Okay. Let me just. So those were my church announcements today. And telling them they can work from home. Lord. Yes. Stick with the AAPC or Certified AHIMA credentials. It's just like those fake nurses in Florida. Ma'am. Here we go. Here we go. I don't know. She said, yep. My diploma says medical billing and coding from 2012. I was valedictorian. I cannot. Giving false hope. Absolutely. Taking people's time as some bogus caca. Exactly. My professor was AAPC certified, so she led me in the right direction. She told me, don't worry about degree right now, get certified. In Atlanta, it's medical and billing signs on every corner like the moving company advertising. Oh my God. Oh, Jesus. These individuals are getting jobs for entry level $12 to $15 an hour. Doing what? What are they doing? Are they coding? Is somebody? Oh God. Okay. So those were my church announcements for the week. Mr. Jesse, did you have any church announcements?
No.
Okay. Oh Lord. Oh child. Well, since we're talking about these credentials, let's talk about AHIMA and what AHIMA is now doing in the world of micro-credentials. Now, I talked about this when I came back from the leadership symposium, that this was coming down the pipe. Well, they have put the information out here in these streets, and AHIMA tells you that these micro-credentials will help accelerate your healthcare career with skill-based micro-credentials. A micro-credential demonstrates focused expertise for skill sets aligned with employers' needs. Certification and traditional degrees offer a broader level of education related to a particular field. Micro-credentials allow you to demonstrate focused knowledge to employers. They also take less time and resources to complete. With skill-based hiring on the rise, AHIMA micro-credentials help you accelerate your career and achieve your desired goals. Micro-credentials are stackable, so they can be combined with other micro-credentials. They take less time to obtain than a certification or a degree. They focus on a particular skill and not the broader subject matter, so you are only paying for the education you need. Micro-credentials can help you maximize your time and investment to accelerate your career. And they are in demand for hiring managers. More hiring managers are moving toward skills-based hiring in order to meet the growing industry and workforce needs. Yeah. So let me share, Lord Jesus, because we got to see all of this. Okay. So these are the AHIMA micro-credentials that are coming down the pipe. There is a risk adjustment coding, or RAC micro-credential. There's a release of information micro-credential, a clinical documentation integrity outpatient, or CDI for outpatient micro-credential. There's an inpatient identification and matching microcredential. There's an auditing inpatient coding microcredential and an auditing outpatient coding microcredential. And then there are the other certifications. So can we go in here? Let's take a look. So the risk adjustment microcredential is for individuals who conduct risk adjustment coding as part of their role. This microcredential is intended for individuals working in settings such as surgical hospitals, physician offices, medical administrative services, patient accounting, outpatient care centers, insurance carriers, technology consulting services, and management consulting. So you have this assessment that you take. Wait, let me look at this. People seeking the RAC microcredentials should be proficient in risk adjustment methodology. This domain has 5 related tasks. Example of a task: differentiate among the risk adjustment models. Risk adjustment documentation and compliance. This domain has 5 related tasks. Distinguish between acceptable versus unacceptable facilities, specialty types, and care support credentials when reviewing documentation in the health record. Medical terminology anatomy. This domain has 3 related tasks: recognize chronic illnesses and identify common symptoms and treatments for chronic conditions. Quality and regulatory reform. This domain has 4 related tasks: recognize areas of possible non-compliance as established by the Department of Health and Human Services, Office of Inspector General, and its work plan. Foundational coding. This domain has 2 related tasks. Example: review a health record and apply applicable coding guidelines and conventions. And frequently coded hierarchical condition category conditions, or HCCs. The task related to this domain will be assessed in conjunction with the domains and task statements shown above. Individuals wanting to take this assessment should be familiar with many of the frequently coded HCC conditions. Some examples are social determinants of health, rheumatologic diseases, cardiac arrhythmias, common vascular diseases, aneurysms, bone marrow transplant, ostomy statuses, and more. You also have a tab about this assessment. Somewhere I saw what they cost. Assessments are administered through our partner vendor, through, I think that should be instead of internet-based testing portal, and are available 24 hours a day, 7 days a week. Browsers that support Google Chrome, Edge, Firefox, Safari. Candidates have 3 hours to complete the assessment. The assessment contains a total of 65 questions. 50 are scored and 15 unscored questions randomly distributed throughout the assessment. The purpose of unscored questions is to gather data on the performance of these questions. Unscored questions do not count towards a candidate's score. Question types used for the assessment may include matching, multiple choice, or multiple select, true, false, select a blank, pull down list, ranking, and may include scenarios presented as images to assess practical application of skills. There was something else, because I want to say I thought I saw something about how much does it cost. Here. Microcredentials cost less than a certification assessment. AHIMA members can purchase a microcredential for $99. Currently, non-members can purchase the microcredentials for $129. The assessment purchase includes 1 attempt on the assessment, which must be completed within 60 days after purchasing. Was there CEUs? They will earn 3 CEUs if a candidate passes the microcredential assessment. CEUs are only valid for an individual's current recertification period. How does the individual revalidate their microcredentials? Individuals that hold a microcredential will need to complete a self-assessment by the expiration date. Self-assessments will be made available before the expiration date and will be available for purchase through the AHIMA store. Self-assessments will be a learning activity and not a pass or fail. Self-assessments do not provide CEUs, and CEUs are not required for revalidating a micro-credential. We anticipate the revalidation fee will be approximately $49 for all membership types. All right, I'll mute.
All right, so before I comment, I want to read what Shay put in the chat in Clubhouse. And she said AAPC and AHIMA need to start showing their face. People are interested, but they don't know where to go. And this was in reference to this whole NHA association. And I totally agree. I think that, just how the American Medical Association has come out talking about scope creep and how vocal they are about, nurse practitioners and their disdain for nurse practitioners. I think that it's time for AAPC and AHIMA to weigh in, especially on these fraudulent companies who are out here misrepresenting people, because each person that signs up for this is taking away a potential client from AAPC and AHIMA. And it'll save them time and money. It'll just be a win-win for everybody involved. But get into these micro credentials. I'm sorry, I just got a call cat. I think they're ridiculous because people have a hard enough time when they have main credentials getting jobs. So now you're going to come out with this. Right? It's almost like they're trying to back end, and you can't back end. I mean, you have people who have credentials who apply for jobs for 6 months, a year or more. So then you're going to come up with a micro credential. That's not going to get you. And then it's already based off of a certain amount of knowledge. So where did you get that knowledge?
Right, because it says, and this is to answer, I think, the Crafty Coders question. Are there eligibility requirements to take an AHIMA micro-credential assessment? No, there are no eligibility requirements or prior education required. If you are competent in the subject, you can sit for the assessment. AHIMA does offer educational resources if you aren't sure if you are ready to take the exam, but want to obtain a micro-credential. This is foolishness.
Mm-hmm.
Okay. So I thought, because we weren't given a lot of information on the micro-credentials, it was just that they were coming, the more information will be given, and be on the lookout. I assumed, and you know what happened when you assume, that this would be something that you would add to. This would be like a specialty certification type of thing. Like you have a micro-credential in this because you have been shown to be proficient in this area through credentials that you already hold. I thought it was a layer on top of. This seemed to be a layer way below. And to your point, the conversation, at least conversation we were having, was for AHIMA to be part of the conversations with HR and hiring entities to discuss the skills that we possess, not throw a credential or micro credential on top of it to say, well, this is what it looks like. No, we've already been, broadly or not, because even though we may have achieved a broader certification, we've specialized in the work that we've done. We've specialized in whatever path we've chosen to pursue using the credentials that we have. So let's provide the information to those who are in those decision-making positions, for them to know this is the skill set that they come into. These are the domains of the skill of the credentials that they currently have, not introduce a whole new level of alphabets that's going to drive everybody crazy because folks don't know what this means and what this is. I'm confused.
So
What'd she say?
What
Because I already
noticed
see you said.
is that what stuck out to me were the two micro-credentials, risk adjustment and clinical documentation integrity outpatient. Now, the fact is not lost on me that AHIMA does not have their main credentials to address either one of those, because the CDIP is supposed to be neutral. It's supposed to be able to use it inpatient and outpatient, but there are outpatient questions on the actual exam. So to me, it's just like it's just a failed attempt at trying to like offer, look, just come out with some more credentials and another exam that's on the same level, on the same par as all your other already existing credentials. I just think this is bogus. It's a flex, and I call capital on all the gatekeeper behind. But I want to read, before we go, I want to read what Shay put in Clubhouse. The real question is, are these credentials for health information employees or are they for nurses?
Oh. That right there is a classic, because you're absolutely correct. Because yeah. Because if a nurse feels they need a coding micro credential to do CDI, here you go. Wow. Ooh, child. I don't know. This been a dude. I didn't even get to the other. It's coding destroying everything. I didn't even get to that. Even though I reached out to Michael Connolly, because he was once my CEO and he was my favorite CEO. Still one of my favorite CEOs. I digress. But let me talk a little bit about this article that came out, if you didn't hear. Because initially I was in my feelings like, wait a minute, what? Hold up. But then I kind of understand some of the things that he was saying. But I don't believe coding is destroying everything. And I believe, well, let me go to the article before let me go to the article. Y'all can talk amongst yourselves. No, I'm kidding. Okay. So in LinkedIn, and it's been some doozies related to this. Friend of the podcast. I'm about to butcher his name. How do you say his name? The curator of the CEU hit list, Mr. Brian, who was
Brian
Quee. Okay. Who was a member who came in and did an excellent job telling us how we can get some free CEUs. Posted about a week ago on his LinkedIn, said, okay, medical coding community, we need to, wait a minute, let me see if I can put this over here so I can open it up. Hold on. Let's do it that way so you all can see what I see. Do you see what I see? You know, I got a song in my spirit on everything. Okay, yes, you can. Okay. Present, share screen, LinkedIn post. Okay. So he said, okay, medical coding community, we need to speak up. Let's tell the C-suite why medical coding is vital to healthcare. So Michael Connolly was interviewed, and this was just one of the questions or one of the things. I actually went to the bigger article here, and I'll open that up in a minute too. But one of the questions was, what is the biggest problem in healthcare right now? And he said, coding. If you track it down, it destroys everything. Everything. It's insidious and has corrupted the medical record system. It also encourages fraud. Complexity is the ultimate inviter of fraud, and coding executives make more money than doctors themselves. Folks went all in to the point that there's several comments. This person said, I disagree. Michael Connolly's perspective on the issues related to medical coding and billing, healthcare is worth considering. It is important to examine the topic from multiple angles. While he highlights the problems and frustrations associated with medical coding, it is essential to acknowledge that coding itself serves a crucial purpose in healthcare: accuracy and documentation, reimbursement and financial stability, fraud prevention, of evolving healthcare landscape, and so on and so on. But let me go to the article. So it says, close. I don't want all of this. Again, he used to be one of my CEO when I worked for Mercy Health. He was there for years and years and years and years, and he recently wrote a book. So I don't know if this book is tied into. I don't know if this is. Yeah, y'all know how folks like to become relevant because they got something to sell. I don't know. I'm just and let me just also say, at a last minute ditch effort, I did reach out to him to see whether or not he wanted to come on. But it was real late. I just thought about it like, oh, maybe he wanted to. I saw another post and I was like, well, maybe he wanted to say something. So I have put the bug out there if he ever wants to come on and clarify. But anyway, so I think this was that first question that he said. He says, how does revenue cycle management play a role in this? He said 10 years ago, we didn't have revenue cycle management. I think, and I'll just say, I think that was an error because we had revenue cycle management way longer than 10 years. I did a whole reimbursement history of CPT and ICD, well, 9, 10, ICD period. And that has been going on for decades. But anyway, he said now it's $140 billion industry, bigger than the entire U.S. auto industry at $101 billion. These massive expenses add nothing to patient care. And in fact, caregivers are leaving healthcare because of the massive headache medical coding causes. How does coding affect doctors on the front line? Doctors spend about 46% of their time on this. Physicians actually lose income by talking to patients, as that's not subject to coding. Why is the phrase medical necessity so manipulative? Insurance companies use that term to unfairly deny needed patient care. We have made the system more and more complex. There are more than 180,000 codes now. What's the fix? Reforming healthcare desperately needs simplicity as its primary focus. Secondly, the payment model needs to be singular for all the payers. We cannot have each insurer creating unique requirements for the payment formula. And I think that was it from. And then again, folks was going in. This must be one of the dumbest and most inaccurate things I've read here in a while. Again, who is proofing and validating these articles? 10 years ago, we didn't have revenue cycle. 10? Did he maybe mean 20? Perhaps he misspoke. Et cetera, et cetera. So, yeah, I don't understand. Oh, we gone over time. I'm sorry, y'all. But I couldn't not show this. Mr. Jesse, did you want to let me mute?
I just want to say that what he's really advocating for, whether he realizes it or not, is universal health care. Because that's what he's really talking about. I mean, the payment model needs to be singular for all payers. That sounds like universal health care. And I don't have a problem with that. But, the average American is going to be very, very hard to sell.
Yep.
Because the only thing that he said that I do agree with is I do agree that there's too many contracts, there's too many variations. This insurance company, this is the requirement. But that insurance company, that's the requirement. And you can be, a claim can be denied just off of something that they may not be aware of that is in that specific payer contract. So I do agree that there could be some more streamlining on the back end, especially on the contracts, but I don't think but that's not the fault of medical coding. That's the fault of contract negotiations.
Right. I agree. And you're right. It all looks, sounds, and smells like universal healthcare. And I don't think folks are for it. And maybe this is a way to highlight what is happening, or what has happened. Maybe that's where over the last 10 years, that will help the argument for folks to see. There was another comment that I want to say real quick. It was like, why is coding always thrown under the bus? Coders follow ethical guidance set forth by our professional associations, AHIMA and AAPC. Don't say nothing about NHA. Okay, I'm sorry. AMA and governing bodies, NCHS, CMS, and AHA. We don't make this stuff up. We are only doing our jobs as accurately as we can. The payers are the ones who don't want to cover services. A coder is towards the end of the patient's visit experience. The service has already happened, so it's not easy for us to get the accurate documentation after the fact. I do agree our providers are spending more time documenting rather than taking care of our patients. However, this is not, quote, coding's fault. Maybe Michael needs to be a coder for a day and live in the shoes of a revenue cycle manager. Yeah. Somebody else said, I work in revenue cycle management. The coders are not the problem on the provider side. It's on the insurance side. They deny overcoding far too often. When you call the carriers, they either refuse to explain the coding error by saying they cannot tell us how to bill, or the steps, or the reps are so poorly trained they don't know that what something as basic as a modifier is. The problem is denial of care and delay tactics to run out timely filing. The non-payment results in more money for a multi-billion profit model for insurance, while medical providers are not compensated for care they provide. It is insidious and lacks every fiber of morals and business ethics. These companies are now the reason why some facilities are closing doors or shutting down needed services in communities. Also, I think it's supposed to be all for a profit model that serve no one but themselves can cheat. Yes, I said cheat. Nonprofit models that serve their communities no matter the patient's wealth. Yeah, that's just a whole doozy of a thing happening there. Did you want to? Oh, I'm sorry. I thought I saw your hand. So yeah. What coder right. What coder making more than a freaking doctor? Must be the third world doctors they are bringing over. I don't believe that at all. I cannot with y'all. Exactly. And then fraud, I mean, if you go back to the history of why the codes, first and foremost, let me just say this again, putting on my public health hat. Coding was not designed initially to have anything to do with revenue. Coding was for statistical purposes only, to under the diagnosis codes, CPT, all of this was for statistical purposes, to understand the health of humans, to understand what health, what were we seeing. Actually, ICD started out hundreds of years ago as a death list. And so it was listing all the things that people were dying of. And so this was a way to determine or gather data about what was happening, which helps the providers in prevention or assisting with, either curing or taking care of these patients with these particular counters. The number of codes increase on a regular basis because we're getting new and more advanced diseases. People are I know I'm about to say the wrong word, stumbling across diseases every day. And at some point they need to be accounted for. And so that is one of the reasons why we have so many codes and diagnosis codes. And we have so many procedure codes is because we're advanced technology allows us to find bigger, better, quicker, faster ways to be able to treat these conditions. So don't let the number of codes be the reason why folks leaving. How as we've always said, they're not documenting. Half of this, the doctor don't even have to be involved in. Let's start there. The doctor doesn't have to be involved in the revenue cycle management if they did their job up front, which is accurately, completely documenting everything that has happened with that encounter. And they can go on. They ain't got nothing to do with this. They don't have anything to do, even if it's their own practice. They don't have anything to do with this if they do their job. Because nobody will be tapping them on the shoulder saying, hey, doc, could you do such and such? Or, hey, provider, could you also consider this? Or, hey, nobody will be doing that. So you won't be frustrated. You won't have the querying fatigue. You won't have none of this foolishness if you just do your job. But let me come there. I'm sorry.
You're right. But at the end of the day, it's all, I'm telling you, like, my number one term is, gatekeep. But a close second is the compassionate sacrifice. That really lives rent free in my head. So, these benevolent physicians, God bless them. I mean, they're like, they're our version of monks. They just, they really try so hard. Meanwhile, they playing with the church's money.
Woo! Come on now. And in my research, don't get me started, because in the articles, I think the articles that I linked below were the ones that gave the history of all of this. In my research, it talked about how doctors were just putting fees, just charging folks all kinds of stuff. So that's why, the CMSs of the world came into play to say, okay, we need to curb this, particularly because they had an isolated group that they can work with, which were our Medicare beneficiaries. And so they were like, well, no, we need to curb this. First of all, your Medicare beneficiary is somebody that's 65 years old. They can't keep paying these exorbitant prices for stuff that you feel like, oh, let me just add a couple of extra $100 on top of it so we can get this done. No, not at all. So that was where the fraud was coming in. And so they stepped in to do that. Now, everybody is completely correct. The amount, see, I'm about to step, the amount of work that I have to go through and do to look at folks' contracts, like, oh my God, to make sure that they're doing what they need to do in order to get their payment is ridiculous, because you got so many payers, and within a payer, you got different contracts. So you got to look, okay, is this a traditional commercial? Is this fee for service contract? Is this a managed care contract? All under the same umbrella of one insurance company. So multiply that by 10. So if you want to be enrolled in all of these things, then you got to make sure your stuff is so yeah, it can be exhausting. But again, it's not your job, physician. It's not your job. That's what you hire these other people for. Because they have the know-how, like, how to, well, hopefully you know how to practice medicine. They know how to manage revenue cycle. And let folks do their job. Okay. I'm sorry. I feel my pressure rising, and I don't even have high blood pressure. Okay. Let's see. Oh yeah, and then somebody in the other thing, somebody was talking about what doctors is coding. Coding what? They clicking a box. They checking something. The algorithm is doing it. What are they coding? What have they ever coded? Now, don't get me wrong. You do have some providers who have made it their life's work to understand this and have gone out and got certifications and done all of the things. But that ain't your job. That ain't something that you do on a regular basis. I mean, unless you don't have the staff or whomever to assist you with that. But that was something that you chose to do. It is not linked to what your job is as a provider. Not at all. The providers make themselves a part of the coding process. They don't trust coders to put the codes in because NHA got folks in here billing instead of coding. Ma'am! Exactly. Well, to that point, you might be right. You might be right. Yeah, I think y'all better make sure y'all looking at these resumes and getting do an assessment, do your own individual assessment of these people and make sure they know what they're talking about when they come through your doors. Don't just hell, that's everybody. That's everybody, regardless. Because you could have all the certifications of the world. You could have had your certification 30 years ago and may not know what is going on today. So do that for everybody. Oh my God. Oh, okay. Mr. Jesse, any final thoughts?
I'm good.
I feel like I have overwhelmed you today. I feel like there's just so much bubbling in there and you don't want to give it to me. And I get it. Because this has been a lot. Yes, that's what I'm saying. Give them a coding test to get hired. Do your own independent assessment organizations to make sure that these people are meeting the spirit of what it is that you need. Don't just put a body in there. And for God's sake, yeah, do that. Whew, okay. I was going to put a new segment in, what's in your cup in my tea. I forgot we don't talk about the tea anymore. So let's see. Today I'm drinking ginger and turmeric, coconut mango, and pomegranate green tea. I knew it was a doozy, so I had to have 3 bags because Lord knows I needed it as strong as it needed to be. Jesus. She said I need a nap. Yes. Hot. Yes. I need a nap. Absolutely. Yes, I see you. You too. Because it was a lot. And more to come. It doesn't stop. It's like a daily thing. Hell, it even ties up my weekend because I'm getting pings like, well, did you see this? Oh my God. What, who, what, where, and why? Yes, we're doing it all. But luckily, we have this forum here where we can try to catch some of this foolishness and have a conversation about it and get your thoughts on what you're seeing and what you're feeling as it relates to our profession. Yes, I think, I did have the NHA certified billing and coding specialist. I'm gonna post that in the thing too, so y'all can see that because that was a little, that tickled my spirit too. But anyway, thank you all again for joining the Saturday morning tea or checking out the replay. I know we've gone over today, but we missed last week. So was the tea spilled today? Yes, I've heard it's been piping hot. Oh my God, my blood pressure, y'all blood pressure. I didn't even lightweight muted Mr. Jesse, and I'm shocked because he's never without words. So yeah, Mommy Picasso in the Clubhouse said instead of blaming insurance, they blame coders. Yes, they do. Leave us alone. We didn't do this. We didn't cause this foolishness. Okay. If this information was valuable for you, help us to share this message because Lord knows we all need to see and hear and talk about it on all fronts. Share this message with others by sharing the video and subscribing to the channel. I still have a goal, 10,000 end of the year. Help me, y'all. Help me. Be sure to follow us for more information on all things health information, compliance, revenue cycle, and medical coding. And as you leave out, don't forget to hit the thumbs up or like button to let folks know you were here and you appreciate it and like the information provided. Also, don't forget to check out the Coding Nurse channel on YouTube where he is dropping gems. He's not silent like he was today. He is dropping gems. He's dropping gems. So this has been a great session today. Mr. Jesse, any final words or thoughts?
It was a lot today. But it was good. I mean, as always, we have very honestly and relevant discussion.
Yes, we do. And thank you all for being part of discussion. Like I said, it's a conversation. We bring the topics, but we want to hear from you. We want to hear what your thoughts on related to some of the topics that we bring. And if you have things that you want us to talk about, by all means, let us know. We will definitely add it to the calendar. So again, this has been a great session. Thank you for joining. And remember to be safe, be kind, and don't wish for it, work for it. Until next time, have a great weekend and take care.